are difficult patients to treat, and there are so many different issues going on with them, it's very difficult to give a good result. So it's very important that when you try to operate on these patients, you follow the Hippocrates principles, first do no harm, and therefore try to do as much as possible in order to reduce complications in these spines. The first is delay elective spine surgery. If the T-score is less than 2, especially in patients with a history of previous fragility fractures, and if you can delay the surgery, please delay it. Start the patient on calcium, vitamin D, and teriparatide, as everybody said, or bisphosphonates. This anti-osteoporotic treatment should be ideally continued for anywhere between 2 to 3 months before surgery, and then continue it for 2 years. I've been doing that routinely for a lot of my elderly patients, and when I go in with, after 2 to 3 months of teriparatide, the fixation of the screws is remarkably different. It is phenomenal. Teriparatide increases the bone mass by about 13% over 2 years. Intraoperatively, there is a significant increase in the mean insertional torque, and it has also a significant reduction in the screw loosening. The second thing is, as again Arvind mentioned, limited correction of deformity. This is the type of patient in whom you do not want to try to restore their normal balance like it was previously. You accept the deformity, because even less is more for deformity correction in the osteoporotic spine. And that is what Arvind was trying to tell you, that he doesn't use minimally invasive, because in minimally invasive spine surgery, the screws are brought up to the rod. The rod is not fixed to the screw, which you do in open surgery. So when the screws are there and you try to bring them up to the rod, the pull-out strength is not there, so the screws tend to back out. And that is one of the problems, and therefore do not try to do too much of deformity correction in these patients. The third, of course, is again vital anterior column reconstruction. The principle, the load of the entire spine is being borne by your implants. So if your implant is not going to have a very good hold, you either have to go multiple levels, as he suggested, 3 or 4 levels above and below, or you need to have a good anterior column reconstruction, because otherwise gradually the whole spine will buckle and your implants will start pulling out. So think about these things. You can use cement, you can use cages. What I like to do is vertebral shortening for these procedures, because then you get bone on bone, and the risk of losing your correction is far lesser. Then of course you have to plan your instrumentation construct. You typically try to use long constructs with multiple points of fixation. I try to use pedicle screws, but a lot of times, as I've done over here, I use sublaminar wires along with the pedicle screws in highly osteoporotic spine in order to augment my fixation. You could hooks or claws to supplement this. That will increase your stability. You could use cortical screws. So these are screws which are passed upwards and outwards as compared to the typical pedicle screw, which goes straight and inwards. And these screws go through the pedicle, have a purchase in the superior end plate, and are shown to have a greater screw strength. Or some people also recommend using 2 screws in each pedicle in order to supplement your fixation. The next thing is the screw design. A number of different screw designs are available. There are dual threaded screws, there are conical screws, which the dual threaded screws get cortical purchase in the pedicle and cancellous screw within the vertebral body. There are expandable screws available where the tip of the screw expands over there, and when it expands in the vertebral body, it takes in more bone around it and improves the fixation. Or you can use what is commonly done today is a cement augmented screws. Here, in the good old days, what we used to do is we used to make 8 tracks. Then we would first inject cement into these and then quickly put the screws on top of that. That is shown to be a little better in terms of strength of fixation than cement augmented screws done with screws which have fenestrations in it and you inject cement through it. The screwing technique is also important. Remember, in an osteoporotic bone, you have only one chance to get it right. So do not, I do the entire procedure, each step under Siam control, starting point, tapping, drilling. It is not out of, we don't use ego over here. Lose your ego and do everything that is required to provide a good result. Usually, get your pilot hole size. I try to direct the screws medially and towards the center of the body rather than towards the end plate, so that if it collapses a little bit, it doesn't cut through the end plate over there. We use longer screws which have purchase across the anterior cortex if possible. We use larger diameter screws, and we then try to triangulate these screws. I always under tap my screws or do not tap in osteoporotic bone for fear that we may lose the fixation. The final thing, as I was telling you earlier, is bring the rod to the screws and bone. Do not reduce the screws to the bone. So adequate contouring of your rod is absolutely vital. And when you are tightening or final tightening your screws with the collars and the nuts, etc., be very careful, because you can actually, the whole screw can be pulled out of the pedicle and you can land up with a neurologic deficit in these patients. So take home message, delay elective surgery whenever possible. Do not try for aggressive deformity correction. That is not your goal. Your goal is to stabilize, give pain relief, maybe decompression. Stable reconstruction of anterior column is absolutely vital. Multiple segment is fixed above and below, and you can use multiple modalities of fixation. You don't depend only on screws. You can use hooks, you can use wires to supplement your fixation. Augment the screws with cement if you feel that is helpful, and use various tricks and tips in order to put your screw in the proper position. Get it right the first time. So use a Siam, do not let ego come in between, and adequate rod contouring. As Ram would always say, plan your work and work your plan. So that's where this is the important. Thank you very much.